Tēnā koutou, tēnā rā tātou katoa, te uri o ngā puhi Ngāti Whātua me Waikato. This is my reflection the last 20 years. So it was a real honour to be asked to speak on my equity experience, and I offered to talk on two great little projects next door in the other sessions on a child health whānau ora randomised control trial, which is totally rocking, and a kaupapa Māori community co-design project that's helping whānau come off insulin as well as getting fruit trees planted. But no, instead I was asked to talk on my cancer mahi, which is a long, convoluted and incomplete story. And here I am in 2000, my first job as a public health registrar. My only cancer experience had been working as a doctor in palliative care for 6 months. And this job was just to gain some experience and get my ticket. I had no idea that it would set the scene for the rest of my career. I was young and starry-eyed. To throw some stats at you, you can understand that the incidence of cancer for Māori being higher is logical given the inequitable distribution of the determinants of health, like income and access to healthy jobs and food, and lower access to screening, and the really poor tobacco, control that's not been happening. But the death inequity is so much higher than the incidence gap. Doesn't make sense. So we should be doing lung cancer screening in New Zealand and better tobacco control, obviously. Our survival data is shameful. It's internationally horrendous, this gap. And these survival inequities are due to two things. The cancer system's designed to meet the needs of relatively well-off New Zealand Europeans, and they do quite well. In our health system, you can only have one thing wrong at a time. Don't be poor and don't have mental health issues or be disabled. And you need to be able to navigate a disjointed, poorly coordinated series of silos that have racist gatekeepers. So that's number one. Number two, there is variable quality within this so-called system. The so-called postcode lottery, the biggest variation's not by postcode, it's by ethnicity. And this slide illustrates lower access, timeliness and quality of care for Māori with stage 3 bowel cancer. So back to the year 2000, when all of this seems so simple, I read up on cancer control and it seemed pretty straightforward. Just follow the recipe on this World Health Organization list and all will be well. This list is basically two things: leadership and partnership, or power sharing at the top, and the rest is just good governance, doing the proper things. So the comprehensive program is what our new cancer agency is going to do, and that's a great opportunity to get all of these things happening for everybody. So we've got some of this already for non-Māori, but hardly any of it for Māori. So, yeah, 20 years and not much has actually happened. My great-great-grandfather had misgivings before signing the treaty. And I don't think we have yet arrived at a time where we can lay these misgivings to rest. So when I started my job, this had just happened. It was a failure of leadership and governance, and that had a disproportionate impact on Māori, which, as I was to learn, is often the way when quality control is lax along cancer care pathways. So my job wasn't cervical, it was breast. The job was to ensure that the treatment pathway was high quality for women with screen-detected breast cancer. And, it was fairly straightforward. There was really good advice on how to do this internationally. So I got a team of experts. We developed about 20 indicators. They didn't get the need for independent Māori monitoring and threatened to resign, but eventually we got the Iru Pō Māori unit to do the independent monitoring. And there were differences by ethnicity everywhere, especially with timeliness. Māori women had to wait longer for everything. But the providers had to develop detailed plans on how they were going to eliminate those inequities, and they did. So we now know that standardising care eliminates inequities. And I and others have failed over the last 20 years to get any other cancer treatment pathway standardised. But we've made a start, at least, with bowel cancer treatment. But, you know, we need to do better, folks. So equity-focused reporting is really, really powerful. It's starting to be done, but it's still, once again, it's frustratingly slow. It just makes people look at the inequities, and if you report it, monitoring things fixes them almost magically. It's fantastic. So this is a good start. We've made a good start with bowel cancer. So we're starting to measure what's going wrong. Okay, so this is a bit of a good news story. It's not all bad. So I helped form a national Māori cancer leadership group in 2012, and I'm now the very proud chair. We have members of Hei Āhuru Mōwai in every national cancer decision-making and leadership group, and we have international collaborations. And we've set up an international Indigenous cancer leadership group. And we're going to have our first meeting in Hawaii, which is pretty cool. So it must have been, I'm just flipping back to 2008, when I heard rumours that a bowel screening program was on its way. I was concerned that it wouldn't be done in partnership with Māori, and that it would increase the cancer and life expectancy gap. And that's actually what ended up happening, despite being on all of these groups. And we're not giving up yet, though. So I worked with my National Bowel Cancer Working Group colleagues, mostly Pākehā surgeons, who are now a group of radical Māori activists, I call them, on this statement, which the then Minister demanded be taken off the Ministry of Health website. Our new statement is even stronger and back on the website. So statements are very powerful, I think. A Māori epidemiologist modelled the impact of bowel screening on the equity gap for Māori and found that even though it will provide health gain for Māori, so it's good, it's going to provide double health gain for non-Māori, so it's going to increase the equity gap. But there are things that we can do. And the creating a screening gap is unrealistic. Dropping the age for Māori is realistic, and we can do that. And that would make the health gain equal. So I was really surprised and overwhelmed by the support for dropping the age for Māori by so many different people all around the country. We had a meeting of high-profile experts who made these recommendations. The National Māori Medical Practitioners Association issued a statement of support. And this graph shows that most Māori bowel cancer is diagnosed before the age of 60, which is the age that the program starts currently. So this is going to happen, but when is the issue? How long do we have to wait for this to happen? I don't know. The next issue is getting Māori into the screening program. It's been a little bit successful. I knew a well-designed invitation process was crucial, so we added a phone call for priority groups, Māori and Pacific, back in 2009. And when the pilot started, they had other priorities, so they didn't get round to doing active follow-up. And as a result, the equity gap was huge. So we developed targets for active follow-up that had to be reported to the ministry, and that worked. They employed Māori and Pacific phone callers, and about 1/3 of non-responders returned their kits. But then there was pressure to either stop or delay the active follow-up because, you know, this cost money. So we did a randomised control trial to justify. So this is over justification. I ended up doing a lot of randomised control trials. It's not my fun thing to do. I'd rather do gardening. But so active follow-up's now built into the national program, and the national team are doing an amazing job. They're getting at about a 50% response rate now, so they're rocking, and that's a bloody good success story. So we're going to eliminate that equity gap in participation, I'm hoping. So I haven't yet touched on our development rights, but it's mentioned in the new cancer plan. Clearly, we as a country are not yet meeting our responsibilities under UNDRIP, let alone Te Tiriti, and I think my great-grandfather was right to be cautious. So the necessary steps are still pretty straightforward. It's not rocket science, folks. But it does require power sharing, and people don't like to share power. So I'm going to leave the final words to Rhys Jones. But on a personal level, over the last 20 years, this has been difficult, full and rewarding at times. The undermining is real and hard work. Our whānau korowai has lain over 5 coffins since I wore it, including my dad, who lost to bowel cancer, so that's been tough. My oldest daughter wants to be a doctor, so one day when she graduates, she'll wear it. And I hope that one day we can have this beautiful imaginary land where we can all work together in partnership to achieve equity.